To guide us through this session, I would like to invite two of the leading surgeons in Sri Lankan orthopedics as chairpersons, Dr. Umapati, Senior Consultant Orthopedic Surgeon at National Hospital of Sri Lanka, and Dr. Nandakumar Amarasinghe, Senior Consultant Orthopedic Surgeon at National Hospital of Sri Lanka. What is it?
Yeah, it's good afternoon and thank you very much for an interesting session on the orthopedics. So we'll have a wide array as was mentioned, and the first topic of the session will be Asia classification. Is it a prognostic indicator? This will be delivered by Dr. Janarthanan Jeyakumar. Dr. Janarthanan Jeyakumar is a consultant orthopedic surgeon at the Neurotrauma Center, which mainly handles the spinal injury. So he's the right person to speak about it. And he is currently the secretary of the Sri Lanka Orthopedic Association and a consultant orthopedic surgeon working in the National Hospital Neurotrauma Center. Over to you, Dr. Janarthanan.
Good afternoon, everyone. I'd like to thank Dr. Umapati and the Trauma Conference for this opportunity. So I'll get the ball rolling. So ASIA classification, is it a prognostic indicator? So what is the ASIA classification? So it's a American Spinal Injury Association classification, which was conceptualized in 1973. It's a standardized system of assessing spinal cord injury. It's vital in both clinical practice and research implications. Helps guide prognosis and rehabilitation planning. And I must insist that prior to this, there wasn't a proper international agreed classification that was available. So the objectives of the lecture today are understand the ASIA classification and its components, recognize its clinical applications, explore its role as a prognostic indicator. So what is the ASIA classification? So as I mentioned earlier, it assesses the motor and the sensory function, categorizes the spinal cord injury severity from grades A to E. So let's get a little deeper into this. So A is a complete spinal cord injury where E is near normal function. So it goes B, C and D, where B has no motor loss, only sensory impairment. C is 50% muscle activity, so grade 3. I'll go into the details subsequently. And grade D is 50% or more muscle function is present. So the components of the ASIA classification has motor and sensory both. So key muscle groups of certain neurodermatomes are assessed, and in sensory examination it's the light touch and pinprick that's assessed. There's a reason for this. Light touch is through the dorsal column and the pinprick is through the spinothalamic pathway. Neurological level is also determined following this assessment, and a zone of partial preservation also can be found. So how is the sensory exam done? So testing is done bilaterally, so that is right and left, to light touch and pinprick. So normally a cotton tip, bud or a toothpick or a pin is used for the pain. We follow the dermatomal and sensory assessment. The sensory key points are used to standardize assessment technique. So the sensory scores are 2 if it's normal, it's 1 if it's abnormal, and 0 if there is no sensation, either pinprick, pain, or is it light touch, either. The motor scoring system goes from 0 to 5. So there is no contraction if it's 0. 1 is when there is visible or palpable muscle contraction but no movement. 2 is when the movement is there with gravity eliminated. 3 is movement against gravity. 4 is movement with gravity with some resistance. And 5 is near normal movement. Now I have put up the chart that is normally available at the accident and emergency or all the trauma centers. So that itself is self-explanatory. You can see that from C2 downwards up to S4, the various dermatomes are there. You have got a right and left. Initially it's a bit confusing, but the right is the right of the patient, the left is the left of the patient. That's why it's intentionally made like that. And you will have to, depending on the light touch as well as the pinprick, a score of 0, 1 or 2 is put onto the sensory part. Motor, only certain motor myotomes can be assessed. So that's why there are lesser motor myotomes that can be assessed. And once the assessment of that is done, then the definitive motor level and the sensory level can be reached. And a complete spinal cord injury by definition is when S3 and 4 have no sensation, and if there is no voluntary anal contraction or no deep anal pressure that's palpated. So full explanation of this chart is beyond the scope of this lecture, but I'd just like to run through this so that you're aware of that. So the total motor score possible is 100. That's because there is 5 motor tomes for the upper limb, 5 for the lower limb on the right side. So you get 0 to 5 score. So 5 into 5 is 5 into 10 is 50 on this side and 50 on that side. That's 100. And there are maximum of 56 dermatomes. So you get 112 into 2. Used to quantify the neurological deficit. The standardized documentation aids comparison and across different centers to pass information. So the importance of clinical practice. It establishes a baseline neurological status as soon as the patient comes in. Guides acute management decisions. Enables communication between healthcare professionals. So even from from a registrar informing his consultant, there is a clear-cut communication pathway. So what is the role for nurses? So this assessment can be done from time to time. So regular assessments can be done, and monitoring of changes or complications, supporting the rehabilitation goals, and educating patients and families about the prognosis. A role for orthopedic trainees: identifying the injury level and the completeness of injury, planning surgical and conservative management, and tracking recovery during follow-up. So I must emphasize that this can be done on admission. At that time, if there's spinal shock, the recording might be misleading. So once the spinal shock recovers, then the scores can change. Similarly, after some intervention, the scores can improve as well. So this scoring system can be done at different periods of time. Tracking recovery during follow-ups and contributing to research and documentation purposes. So what is the prognostic value? So strong correlation has been found between the AIS grade and the recovery. So incomplete injuries, C and D, show better outcomes, whereas early Asia assessment predicts motor recovery potential. So just to summarize that, C and D will more likely to become E, whereas an ASIA A is unlikely to recover to near normal. So studies show that ASIA A grade at admission predicts functional recovery. Example, 80% of ASIA D patients regain ambulatory function. ASIA A patients have the lowest chance of recovery. So what are the limitations? Cannot predict psychosocial outcomes, less accurate in early spinal shock phase, and requires training and inter-rater reliability. So the nursing implications are early recognition of neurological deterioration, tailored care planning, and coordinating interdisciplinary rehabilitation. As far as the orthopedic trainees are concerned, develops understanding of the spinal cord injury prognosis, enhances surgical decision making, and promotes evidence-based practice. Guide in rehabilitation, it guides goal setting in physical therapy, tracks neurological improvements, and adjusts rehabilitation intensity. So as a case example, a 28-year-old male with a T10 level injury, ACR C, initial ACR motor score 52. After 3 months of rehab, ACR D regained partial walking ability. So we're able to communicate as to how the improvement is come about. So there have been some recent updates in the scoring system which has been there for many years now. Digital scoring tools are now available as well. Asia classification is a key spinal cord injury assessment and prognosis. Provides structured neurological evaluation. Valuable for nurses and orthopedic trainees, it supports communication, management, and research. These are my references. Thank you very much.
Since it is a symposium, we'll take the questions at the end. So thank you very much, Dr. Janarthanan, Jeyakumar. Our next speaker is Dr. Dayasivam Gobyshanger. He is currently the consultant orthopedic surgeon at the National Hospital of Sri Lanka and also the president of Sri Lanka Orthopedic Association. So he is here to talk about the important topic we see in the accident service every day, mind the gap, how to deal with the bone defect. We often come across people with bone defects or lost bones at the scene. Dr. Gobyshanger will address us how to deal with that. Over to you.
Thank you, Chairman, sir, and thank you, the committee, for inviting me to give a note here. I was told that mind the gap, whether it was a warning to me, I was wondering, but I thought I can bridge the gap rather than mind the gap. Anyhow, coming to my presentation when it's ready. So when I met Dr. Abhijit, I said, you know, Gobi, I still remember the underground tube station UK, mind the gap. So that reminded me to talk on something in orthopedics. Mind your gaps. Is it the gap between orthopedic surgeon and other specialties? Like plastic surgeon, my colleague, they are there. We always mind each other a lot when it comes to orthopedic trauma, especially with bone loss, skin loss, and muscle loss. Can I have the presentation? Is it ready? Okay. So I don't know what was the intention of Abhijit, whether to have a fight after this. Anyhow, it's always been a challenge for an orthopedic surgeon, them minding the gaps. So we are trying to bridge the gaps. Jana, are you happy to take any questions until that this is ready? Chairperson, would you like to use this?
Yes. Any questions for the prognostic indicator of Asia?
Any questions from the nursing officers who regularly care these patients in the ICUs? But Dr. Janarthanan has pitched the lecture at a very basic level for everybody to understand.
Okay, so right, so I think the gap has been bridged. Right, so had it been a fracture like that, what we see here, it bone heals. So orthopedic surgeon become jobless. But we don't see this that often. Unfortunately, we get always some complicated traumas. So what we get is always a segmental bone defect. It's usually due to high energy trauma. The patient comes with a missing bone, or when during the debridement we take out the bone, or after a few weeks or days the patient comes with infection of the bone, or sometimes the fracture happening in a tumor where we had to resect that bone. A patient who is having some congenital anomalies coming with the trauma, it become a big challenge to us. Right, so when and where this bone loss is a problem in trauma. So if you see this literature, it's very subtle on orthopedic fractures because it was in UK. So we don't have any proper studies in Sri Lanka, but we found out almost 17% of our injuries are a high energy where some kind of bone impact is with some bone loss. So these are 10-year prospective studies in Edinburgh Orthopedic have said it is how the bone loss of 11.4% of all open fractures was most commonly associated with Gustilo 3B and C. That's their studies. And importantly, this was a young active population, high energy trauma patients with men age of 37 years in their studies, and 71% they are males. So in addition to the bone defect, one or more of the following factors usually involved in the victims. They will have some limb shortenings, deformities, prone to get infections, soft tissue deficiencies where they are unable to execute their normal movements, and they will suffer from permanent neurovascular injuries. So what are the factors generally influence the bone healing? So we have factors which are patient factors, which of course the age, nutrition, smoking, medication, etc. The injury factors for any metaphyseal fractures during the richer blood supply and the attachments of muscles, they heal faster. Comparatively, femur fractures, bone deficits can be dealt easily because they have high potential to regrow or reabsorb when this augmented with other orthopedic procedures. Of course, the last not least, the surgical factors involve the technique of the surgical approaches, stability, and the soft tissue conditions at the time of surgery, or how do we handle. So how can we bridge the gap in trauma in early and late cares? We may see patient with the primary loss. We may have issues, the bone is there, but there is no soft tissue cover. That bone become a dead bone if we don't get early cover of the soft tissues. Patient come with a reasonably good bone, but ending up with some acute and chronic osteomyelitis where we had to resect the bone. And we put the implants, an implant fails, and that bone segment become dead. It become a surgical complications. Segmental bone defect. So segmental bone defect is a bone void that will not fill without intervention. So in general, in adult patient, cortical bone defect generally has circumferential loss more than 50% or length of more than 2 centimeter. We need to take an extra care. The loss can be a cavitary or a segmental bone loss. So there are 3 types of skeletal defect generally we see. Intercalary defect, where the bone middle part is segment. Segmental defects, where it is more than just a bone, it will be more than 3 or 4 involvement of segments. Combination of both. So we try to find out the literature. Is there any classification for bone loss? What available at the moment is Solomon classification of the bone defect. It's generally a guide rather than a classification, we would say, where when it comes to the level of A, you have a minimally invasive techniques, or you can still do less care on the bone loss we can get away. B and C, we need to have surgical techniques a lot. When it comes to the D, the amputation may come as a choice rather than a reconstructions. Similarly, this one article I found, the techniques for management of bone loss, suitability of the anatomical location and the size of the defect, the guide goes. So these guides are there, you all can read. This is to help when you are planning your bone segmental loss management. But bone healing is predicted on mechanical stability, a favorable biological environment, tobacco cessation, glycemic control, nutritional optimization, and management of metabolic and endocrine conditions. When you have an open bone loss, the key surgical principle when it comes, early debridement. The first, as I always say, that it should be done by the senior most experienced orthopedic surgeon, which doesn't happen the same way. I don't know about the rest of the world. Removing all the dead and devitalized tissue. And the challenge, the second one is soft tissue coverage. When the bone are exposed beyond for 70 and nerves more than 72 hours, it's very important. You should get the cover within 72 hours. The stabilization of the skeleton. Early and adequate immobilization of the fracture is essential even for the soft tissue to heal, or even the existing bone pieces which are still attached to the muscles may be devitalized. The management options for the segmental defect that we have at the moment are autograft, considered to be a gold standard, subject to challenge by others as well. Vascularized graft, usually from fibula and iliac crest and ribs. I don't know if the thoracic surgeon agree on that. The one popular method is the muscular technique with the membrane-induced techniques. The bone transport, thankful to the newly developed monorail and other Elizarov techniques. When these are not feasible or practically possible, they always can do some acute shortening and lengthenings. So, gold standard autograft is a cancellous bone graft, acts mainly as a osteoconductive substances, with a smaller contribution to osteogenic cells and osteoinductive factors. But if the gap is more than 5 centimeter, they will be resorbed by the revascularization and chances of a necrotic graft tissue. So we have to be, when this gap is more than 5 centimeter, they have observed, they will be resorbed and they become a necrotic graft tissue. So these are a couple of examples of surgeries that we have done. One on the left you see is the iliac bone graft, which is a common donor site for us. And the other one is, in addition to the fixation, the gap has been filled with the graft, which removed from the surgical site. So what is the current state of affairs with vascularized graft? It was introduced in 1970s, has been a preferred choice for more than a decade. And especially the gap is more than 10 centimeter, but with improved included membrane and distraction osteogenesis, they have lost its popularity. What are the challenges when you are doing this vascularized graft? Technically demanding, loops, sometimes the busy plastic surgeon need to be bothered frequently. Of course, time consuming, nurses are not very happy. It may be associated with major complication from the donor side as well, and it's not available in all centers, so you can't just ask everybody to adopt this measure. What is the next one is membrane-induced technique, muscular graft. It's a privileged compartment limiting autograft resorption. The cement spacer maintains the gap, and it induces a natural vasculoendothelial growth factor, TGF-B1 and BMP2 and co-binding protein factor A. It improves the graft consolidation by stimulating the cell progenitors. Not only that, they differentiate into an osteoblastic lineage. The bone defect is stabilized by an external fixator or an internal fixator, is both possible. Second stage surgery typically completed 6 to 8 weeks later after the primary surgeries. They can cover from 5 to 14 centimeters of segmental bone defects, but the needs of sufficient autograft to allograft must be in the ratio of 3:1. So these are a couple of examples where we have done the muscular autograft. One of the tibia, primarily with the fix with the nail and the bone cement. Then subsequently we grafted it. And the other one, it's about autograft healing again with the nailing. Bone transport, it's done by many techniques, Ilizarov, LRS and nails. Reliable, minimal risk injury to soft tissues, ability to bear weight from the early raise, no limits of size of defect. You can do from the top and bottom dual way as well. The disadvantages are it's a time consuming procedure. Sometimes it goes almost an year. Quite a lot of psychological burden, especially in young patients as well. Significant in Sri Lankan perspective, we have we found that the pin track infection is about 80%, and it is across the world it reaches high as 80%. So principle is you can have a monorail or a second fixation later on, or you can have a Ilizarov from the beginning. What are the non-operative management options when we have bony gaps? Brace immobilization, let the fracture to fill with some fibrous tissues. When you have bone stimulators, you can apply and see whether they help with that. When there are complete contraindication for any of the surgical intervention, you have to find out non-operative management. You can allow synovial pseudoarthrosis, especially in non-weight bearing, where patients' need and demand is less. And sometimes we have, like the Girdlestone procedures, we have seen people happy with some mobile non-unions. The question comes, retain or resect of bone segment. This bone segment, the piece of segment intercalated, whether you want to take it out or leave it. The general teaching is a tuck test. Grab with the 2 fingers, not the thumb and index, but with the other 2 fingers, or take your forceps and pull it out. It comes, remove it. But it is not all the time. There are contraindications for above scenario. There are enough case reports, but not a good study, I believe, because you can't do as a study, where the segmented has been incorporated, especially in femur and humerus, they have revascularized. So always remember, there are instances where you will have to retain the bone piece. The second question, whether to retain or resect the limb. Limb salvage is always often preferred. New advancement or new advanced techniques allow for most of the limb salvage, even in case of large segmental bone loss. But keep that in mind. Amputation may be necessary and could be a best early option for severely mangled limbs with extensive soft tissue loss, neurovascular compromise, or prolonged period of ischemia.
Thank you, Gobi.
Can you go back to the last slide, please?
Questions we'll ask at the end of the session. And next speaker is Dr.
Some of my experience. Thank you.
Thank you very much, Gobi. Right. Next speaker is Dr. Udai de Silva, the Senior Consultant Spinal Surgeon in National Hospital of Colombo. And he's going to talk to you about the very important topic in the primary survey. You have to stabilize the spine while you are transporting. So it is over to you, Dr. Udai.
Good afternoon, everyone. Thank you so much, Nandakumar, for that kind words of introduction. My topic is spinal motion restriction prior to transportation in suspected cervical spinal injury. This is the overview of my lecture. I will talk about the history of cervical spinal motion restriction, what happened in the past and what is happening in the present era, and then some something about pre-hospital evaluation, application of cervical collar, and how to do the supine locked roll and do an on-field stabilization. And then I'll talk about special issues regarding certain groups of people, like injured in the prone position and injured in the seated posture, and the helmeted individual and the pediatric patient. And then I'll go on to discuss about the Canadian C-spine rule and how it can be used effectively in on-field algorithms. And if time permits, I'll go and discuss pros and cons, and finally the take-home messages. Right. Now, history. In the history, there's no mention about spinal immobilization up until the World War II. If you consider the Napoleonic Wars and the World War I and the Spanish Civil War, there have been a lot of medical improvements with the wars, but nothing has happened regarding cervical spine. The cervical spinal things came into being after World War II. So before World War II in late 19th and early 20th century, it was advised not to treat these cord injuries, and as it was taught that spinal injuries are fatal regardless of any known intervention. Right? So was the pre-hospital care. So then, post-World War II, Sir Ludwig Guttmann, a gentleman from Stoke Mandeville in UK, in 1963, he started expert conservative management of the spine. Then this nihilistic attitude regarding the spinal injuries started changing. So when it started changing, later on in 1970s, ATLS adopted these principles after Dr. James Kenneth Steiner, who the founder of the ATLS, and then the American College of Surgeons adopted his this thing in 1980, and it was incorporated into ATLS protocols. So what matters most in the cord injury is protection rather than detection. Detection can wait. Protection takes the priority. So now the reason why it is so is that degree of return of neurologic function after spinal cord injury is often poor. So great care must be taken on site to maximize the opportunity for recovery. So the prevention of further injury to the spine by proper immobilization should be the first step. So that goes together with A, B, C, D, E. So that's why the C, the small c, the simple c came in front of A, that is cervical spine, inline manual inline cervical spine stabilization plus A, B, C, D, E. Right. So something about cord injury and the bone injury. Now in a spinal injury, there are two components. One thing is biomechanical instability of the bony spinal column. That is what we orthopedic surgeons look after. The other more important thing is physiological instability of the spinal cord itself, which no one is able to look after because there are issues like this. Now, injured cord has cell membrane disturbances, and it has lost the autoregulation capability, and the blood-brain barrier is disrupted, and cord cannot protect itself from complications outside, such as hypoxia, hypotension, sepsis, and hypothermia. On top of that, if the bony spinal column is unstable, then there are other problems coming into play. So on-site motion restriction of bony cervical spine helps protect the physiological instability of the cord. So how do you do on-site management? Now, first thing is, do not move the injured until a quick differential diagnosis is arrived at and the spinal injury is ruled out. And then, if the injured is unconscious or has altered level of consciousness, or has bilateral neurological symptoms, or has midline spinal pain or deformity, then detection can wait, as I mentioned earlier, protect the spine. Even if these are not present, suppose if these are not present in a patient, avoid premature exclusion of spinal injury and do a thorough evaluation and do a preliminary immobilization of the spine. Though, how do you do that? So first thing is you achieve neutral alignment by keeping the neutral position of the head and the neck. if the head and the neck is not in the neutral position. But this should be done with caution. It should be stopped if the injured has increased pain or if there's a change in the neurologic status during the movement. So this is a very, this should be done very carefully. And then while doing this thing, distraction or traction should be avoided as much as possible, right? Then comes manual inline stabilization, which is called MILS, M-I-L-S. They are where the rescuer kneels above the head of the injured while facing the injured and place both hands under the head, cupping the occiput with the palms and fingers grasping over the mastoid processes. So this should be followed by more definitive stabilization as soon as possible. Now this is done usually like this, either coming from the head end of the patient or from the side of the patient. Right? And then comes application of the cervical collar for more stabilization of the spine. That's a cervical collar that we use usually. First thing is to size the cervical collar by using your fingers. Using the fingers, you find out the gap between the trapezius, top of the trapezius, and the mandibular margin. So that is used as a guide to adjust this cervical collar like this, right? You measure that from the blue part, that is the plastic part. The white part in the inferior margin of the collar is very soft. It's not hard. So the hard part is the blue part. You take that as a guide and then measure that and adjust the height of the cervical collar according to that, and then hold the collar in a manner with the index finger and the middle finger of the right hand as what is shown there, and then insert it from the side of the patient while your assistant is maintaining the manual inline stabilization of the cervical spine. So that's how it's done. Once that is done, the next thing is to transfer the patient onto a spinal board by log rolling. So there are various designs of spinal boards. Spinal boards have a head of backboard which has room to place the head blocks at the top of the board, whereas the foot end is narrower. There are holes where the straps can be inserted and tied like this. And then, so there are two ways of transferring the patient who is on a cervical collar now onto the board. The one way is by log rolling, and the other way is by lift and slide technique. So I will show these two techniques graphically. Now in the log rolling technique, at least you should have 1, 2, 3, 4 people, a minimum of 4 people in order to do a proper log roll. The leader stands at the head end of the injured, providing manual inline stabilization. There should be 2 assistants who reach across the body. Their arms should be crossed. And on the leader's verbal count, the others will do the smooth roll, log rolling of the patient towards them. And the third assistant then places the spine board behind the victim's injured person's back, and then gradually he is lowered onto the board at the leader's direction. So this is how it's done, and I have enlarged these things for the clarity. So the one who is at the top end is the rescuer, the leader. Then there are 2 people, and then they grab the patient from across the body and then turn the patient onto the lateral position, and the third rescuer, the 4th person, puts the board behind that, and then he is gradually lowered onto the board, and then the straps are placed. Right. Then comes the lift and slide technique. It is no need to explain that. It is graphically represented in that. That needs 8 persons, 4 on either side. Head end, there's a leader, and then the 8th person slides the board underneath, and then the patient is lowered. Now what happens to the patient who is in the prone position? In the prone position there are issues. If the patient has the cardiopulmonary or compromisation or mentally altered or unconscious, then you have to turn the patient onto the supine position without waiting for the board to arrive. Now, if the patient is conscious and communicating, then there's an opportunity for you to wait until the board comes so that you can straight away roll the patient onto the board rather than doing two maneuvers. So that's the advantage. So what you do is the leader starts with arms crossed in the initial part, and then the arms will be uncrossed at 90 degrees. So at 90 degrees, there should be a pause given to the persons who are turning so that they can readjust their bodies. Then the patient is taken onto the board. So this is again graphically demonstrated there. Now the victim is in prone position, and then gradually she is turned and then on the board, and then the straps go. Then comes injured person in the seated position where a Kendrick extrication device has to be used. So what you do is manual inline stabilization given in the seated posture like this, right? And then the collar is inserted, right? And then now the collar is in place, and this is the Kendrick extrication device. It goes behind the patient while the first rescuer holds the patient's head and neck while the collar is in place, and then it is inserted like that, and the straps go across the body and the forehead and the stick. Now this is a clearer picture, and then after that the patient has to be lifted off the chair and then put onto the board like that gradually, and now the patient is on the board, and then the straps, the blue colored straps there are the straps of the board. Right, so that is about that. And then a person who is on a helmet, wearing a helmet, what do you do? So you reach the patient's head in like that, and then the first rescuer grabs the head as well as the helmet, and the second rescuer comes and unstraps or cuts the straps of the helmet, and then he holds with his right hand the chin and the mandible, and the left hand goes underneath the occiput, stabilizing, and then gradually with rocking movement the helmet is removed, and then the first rescuer comes and holds gives the manual inline cervical stabilization again, while the second rescuer applies the cervical collar. So that is how it's being done. Once this is done, there should be foam rolls going on either side of the head to stabilize the patient like that, and now the patient is ready to be transported to the hospital. Now in a pediatric patient, the problem is in children who are less than 80 years old, they have a larger head proportionately compared to the body. So because of that, when they are put on a board, they are in a flexed attitude. The cervical spine is in a flexed attitude. To prevent that, there are special boards available where either there is a hole cut for the head, or the shoulders and the spine area, rest of the spine area has a elevated part so that the neck doesn't go into flexion. So is cervical motion restriction prior to transport evidence-based? Yes, it is evidence-based. There's about 2 to 12% incidence of cervical spine injuries, and if these injuries are overlooked, you run into serious troubles for the patient. And then when there's low GCS, loss of consciousness, the spine injury rate becomes higher. And then penetrating neck injuries pose more threat to the patient. So does everyone need spinal motion restriction? So that's a controversial thing. So because of that, recently we have gone for selective spinal motion restriction called SSMR, using Canadian C-spine rule. Canadian C-spine rule is about, it divides patients, it categorizes patients into high risk, low risk, and no risk, depending on what the risk factor the patient is having. Depending on that, if the patient has low risk, no risk, they can be, they do not need spinal motion restriction, but if they are high risk or low risk, they need spinal motion restriction. So selective SMR is important because there are conflicting findings about the risk of secondary cervical spinal injuries. 1 in 5 cervical spine trauma actually sustain, only 1 in 5 actually sustains spinal cord damage. So why immobilize all the people? Then the other thing is there are no significant differences in immobilized versus non-immobilized patients' neurological outcomes when it comes to the studies which have been published. But most of these studies are retrospective analysis. There are no single prospective analysis or randomized control trials on this. This is a study which I found which is from 2019 from Scandinavian Journal of Trauma, which says vacuum mattresses are better than collars and hard spinal boards when it comes to cervical motion restriction because of the issues that I was mentioning. And I'll skip this slide. Now, there are issues with cervical collars like ill-fitting, uncomfortable, wrong size, and incorrectly applied ones, which are causing more trouble than that. And then there can be, still there can be spinal motion while the collar is in place. And then it can elevate pulmonary, risk of pulmonary embolism, ventilator-associated pneumonia, and intracranial pressure. And there are problems with boards. So all these things together brings us to these take-home messages. Use selective spinal motion restriction rather than immobilizing everyone. For patients who are alert and responsive, you can apply the Canadian C-spine rule and see how the risk is, and then apply spinal motion restriction depending on what they need. And if the patient has a reduced level of consciousness, consider to remove the cervical collar in intubated patients. This happens while the patient is in the hospital, not in the pre-hospital period. And then lastly, overarching guidelines are use Philadelphia collar for those who cannot be confidently cleared clinically, and aim for faster radiology consultation and exclusion of the cervical injury rather than waiting with the collar on. And then if the patient, having done all these things, if the patient does not tolerate the cervical spine precautions, there's a query whether in that situation whether to continue to apply the cervical immobilization or not. Thank you very much.
Thank you very much, Dr. Udai de Silva, for your descriptive lecture. And next speaker is Dr. Eshan Jayaweera, the consultant orthopedic surgeon, National Hospital, and he's going to talk to you about the sports injuries of the knee joint. It's over to you, Eshan.
Thank you, Chairman, sir, and thank you for the organizers for inviting me. Okay, so it's going to be acute knee injuries. So acute sports injuries that present with the knee injuries that present to the A&E. The knee injuries as a whole is a vast topic, so I'm going to only concentrate about acute sports injuries of the knee. And also those injuries, we can't discuss all the injuries, how to treat, what to do, but we are going to see how we are going to first initially manage these patients who have suspected knee injuries that present to you at the A&E. So right. So, so what are we going to learn today? So, can't see very far. The knee. So go back one. The objectives. So the objectives of this talk will be a little bit about the introduction. We'll see the causes of acute knee injuries and see how we are going to approach these patients who have come with a knee injury to your A&E, and see what the immediate interventions are, and see when to refer, and the take-home message. Okay, so if you look at the knee injuries, it's a very common injury that you'll see that comes to your A&E, and especially with all these sporting activities currently going on in Sri Lanka, so school level, club level, international, national level, invariably in your A&E, you're going to find some person or athlete or even recreational people coming with a lot of these injuries to your A&E. And the incidences are increasing day by day. And also the thing is, it's affecting young patients. So, yeah. So, and then some of these patients who come with a knee injury, it could be the result of end of their professional career. And also, if you don't manage these properly, it could have long-term consequences with arthritis and other deformities and things like that. And also, so this is most commonly seen in sporting activities that lead to twisting, turning, sudden change in movement, landing in one foot. So those kind of sporting activities are more likely to end up with acute knee injuries. And appropriate interventions by appropriate timely care can improve the outcomes and long-term outcome of these patients. Right. So if you look at the causes of knee injuries in sport, we have the common ones, the less common ones, and the ones we shouldn't miss. So the commonly you see meniscal injuries. So mainly the medial meniscus, also the lateral meniscus as well. Then you have the medial collateral ligament injuries, the ACL injuries, as well as some PCL injuries, not uncommon, but you see it. So, and then the patella dislocations are very commonly seen in the A&E, right? When it comes to less commonly, you might see the extensor mechanism injuries where you might end up with patellar tendon ruptures, quadricep tendon ruptures, and less commonly the LCL, lateral collateral ligament injuries are also there. And then you have other avulsion injuries that you might see around the knee joint, especially the biceps femoris tendon at the back. And then not to be missed are the dislocations that will come, the fractures of tibial plateau fractures, osteochondral fractures, things like that, so, and multi-ligament injuries, so are not to be missed. So the common ones we see commonly, and you're bound to see in your A&E every time on a casualty. Okay, next. Okay, so how do you now approach, now this patient is at your A&E, suspected of a knee injury, a sporting knee injury, and how are you going to approach these patients? So what you want to find out is, does the patient have a significant knee injury? Okay, so your history is going to tell you a lot of details. So you want to know the mechanism of injury. You know, if it is significant injury, you know, a high energy injury like a road traffic accident or fall from a height, or, you know, a high energy sporting injury, rugby injuries, you might have a tackle, you know, quite a lot of force, a lot of people falling you know, it's going to be a significant injury. And amount of pain and disability at the time of injury. So if you know in the history the patient is unable to go back to sport, or a patient following an injury, say motorcycle accident, that's not a sporting, but unable to weight bear, things like that, you know, is a significant injury. And then the timing of swelling. So if you know, if acutely, if the knee has swelled up, you know, it's a hemarthrosis, that means it's more significant than a gradual onset swelling. So the degree of disability at the time the patient presents to you is in distress, things like that, you know the patient is more likely to have a significant injury. Okay, so the main goals of assessing these patients are to find out which structures have been damaged around. So the knee has so many things that can go wrong. So your goal will be to find out which are the structures, or what are the structures that have got affected, and to what extent the damage has occurred, and also to determine the degree of the joint and limb disability, so that you can actually provide the safe and appropriate initial management to these patients. So if in the history, so what's the important? The mechanism, the precise mechanism of injury. So if somebody tells you the mechanism, we can actually predict the injury. So if somebody says the twisting injury during, say rugby or football, you know things that can go wrong, then you know what, okay, this is the most likely injuries that could be there. Like sometimes even a rugby, you can have a valgus stress due to a tackle from the side, from the outside, with the valgus force, you know what injuries you're most likely to end up having. or it can be a direct impact. You could have fallen on the knee. So, things like that, you can predict the injuries. So you can actually, if in the mechanism, you can ask the patient to, if he is able to demonstrate on the normal limb what exactly happened to the injured side, right? And also make sure that you ask them whether they were able to weight bear and continue playing, or whether they had to stop and come out to the field, or what happened. And so when you look at the swelling, so important to ask about the swelling of the patient. The degree and the onset of swelling will tell you, okay, if it is very acutely swollen, if the patient says, my knee swelled up as soon as the injury occurred, it's bleeding inside the joint. It can't be an effusion. So it happens within 1 or 2, hours, like very quickly. The knee has swelled up by the time they present to you. Or if it is gradually getting, swollen, it's more likely a reactive arthritis and effusion rather than a hemarthrosis. So if you look at this table here, you can see immediate hemarthrosis. What are the injuries? So if it's anything which is intra-articular can cause a hemarthrosis. The ACL and the PCL are intra-articular structures and vascular. So when it bleeds, there's hemarthrosis. That gives you an indication that this could be a ACL injury as well. And also patellar dislocations, especially if you have like osteochondral fracture with the dislocation, that's very likely to be hemarthrosis. And also if there's a big chondral damage, hemarthrosis, they present with that. And not common, but deep MCL sprains also can come with hemarthrosis. But if the next day the swelling occurred and it's slow onset of it's a effusion, synovial issue, most likely a meniscal injury, or even a smaller chondral defects might be like that. So, but usually with pure MCL and ACL ligament injuries, which are extra-articular, you won't have hemarthrosis or effusion that much either. So, right, so in the history, now all this is very important. So all these things in the history that you need to find out will give you a clue as to what the injuries are. So other thing that will guide you as to what the problem might be is asking questions like, did they feel something move or pop inside the knee joint? So most likely, if they felt something going and coming, that means like it could be a patellar dislocation, or commonly a ACL injury as well feels like that. Or if there's clicking, locking, then it could be a meniscal or a bucket handle tear or something like that, or a loose body that has got dislodged, causing the locking sensation, or a displaced meniscal tear. Giving way, it's a very frequent thing that patients come and tell, my knee gives way. So it could be due to ACL, it could be a meniscal, it could be many things, like even articular cartilage damage or patellofemoral pain, or all those things can look like the patient comes with giving way symptoms. And if very commonly you think you won't hear, but patient come and say they heard a sound, a pop or a snap, it's a ACL tear unless proven otherwise, right? So all these things you will be able to find in the history and know what you're dealing with, even by just the history. So also don't forget, like I said, ask what happened, the initial management. Sometimes if they are in the playing field, whether they were able to carry on playing, or sometimes they are so enthusiastic they want to keep playing. So whether they went back to playing and re-injured, or whether they were kept iced, strapped, non-weight bearing and properly brought to hospital. So what the initial care was, who saw them, all that will be important in your history. And the previous injuries and previous surgery, whatever that has been done to that side, you should find out. And also the occupation and type, and whether it's in what level these guys are in, whether it's professional level, recreational club, school level is also important, and what the, whether they want to go back to play or not, all that is important. Right, so, okay, once you have done that, then you want to examine these patients. As usual, orthopedics, we all go by the usual look, feel, move, special tests, and the distal neurovascular status. So in the look, you look for obvious deformities, swellings, open wounds, scars, like contusions, things like that. Then you feel, you do the movement, then you do the special test to identify what the special injuries, the ligaments or menisci, I'll come to that. And don't forget the distal neurovascular status, especially check the distal pulses, capillary fill time, sensation, all of that has to be checked. and can calculate the ankle brachial pressure index if you suspect a multi-ligament injury or a knee dislocation. Okay, if you look at some of the tests, if you ACL, what are the most sensitive three tests we know? The Lashman is the most sensitive along with the anterior drawer. So pivot shift usually is also, you normally do it in theater. That causes a lot of instability if there's a pivot shifting. It's an indication that you need ACL reconstruction as well. So PCL injuries, the most sensitive will be the SAG sign. There's no time to show all these things, but I'm sure you should learn these physical examination techniques. Posterior draw and the reverse Lashmans. All those can give you a very good idea that what the injury is. And also meniscal injuries, more sensitive is the joint line tenderness along with McMurray's and Apley's test. And MCL, LCL, the valgus or varus stress test will be able to diagnose whether there's you can even grade the injury to grade 1, 2, or 3 according to how it opens up. And next thing you do obviously the basic x-rays. Usually you take the AP lateral skyline view. If you can take a notch view if you suspect ACL injury. You can see avulsions actually sometimes in the notch view. The MRI and ultrasound are also helpful. So in the x-rays, I mean, we see a lot of people coming. So how do you decide whether you actually need x-ray? Like in the ankle, we have the Ottawa rules for knee x-ray indication. So if anyone who is over 55, there's tenderness over the fibula, tenderness over the patella, and is unable to bend the knee to 90 degrees or weight bear 4 steps, consider do x-ray for sure. And any high-speed injury, children, do x-ray as well, right? So in the x-rays, what we look for, the main things we are looking for: tibial plateau fractures, avulsions, tibial spines, and osteochondral fractures sometimes can be seen, and Segon fractures are usually like shown in this x-ray. It's an indication that the patient would have had an ACL injury, right? In children, you can do comparative size, check both sides. You can, because you might miss a physeal injury. And also stress, sometimes if you are not sure, you can do stress x-rays, valgus or varus stress x-rays will show the opening up of the joint. So MRI is also very reliable for soft tissue injuries and other to diagnose properly. I mean, we most likely will end up with MRI, which will give you most of the diagnosis, but make sure you correlate clinically and not just by going by the MRI. And ultrasound also will detect good for these complete or partial patella or quadricep ruptures, but when you have MRI nowadays, ultrasound is less useful. Okay, so remember, if you have a dislocation, make sure you might end up needing, if the pulse is not there, CT angios or MRI angiograms, right? So, okay, so what do we do when you see these patients immediately in your ANA? Like in sports medicine, you can't get away from price or RICE. So first thing, you protect. That means you make, or in the field, you take them out of the field and not let them play again, right? And rest, ice, compression, elevation. All these things will mainly allow to control the pain and reduce the swelling. So practice price or RICE. Make sure you know this. And then you immobilize, especially if you suspect any splint or even a plaster cast or brace will help to suspect the fractures, instability, or any joint, painful joints, just immobilize, right? Okay, what are the things you should immediately do? And if you see something like this in this picture, you know, obviously there's a lot of deformity. Obviously there's some dislocation. You don't send them to x-ray, you urgently reduce this knee dislocation, okay? And then you stabilize, and then you can send for further investigations, because with this you know. And then other important thing is always monitor and check the distal circulation, and keep monitoring, because you might have intimal tears and subsequent loss of the pulse might be there. So inform the vascular team as well. And if there's multi-ligament injury, sometimes also you have to reduce this, stabilize this, and make sure you check the pulses and refer urgently. And sometimes you come with locked knees. Patients, the knee just can't be moved. It could be a displaced meniscal injury or a bucket handle tear or osteochondral fracture that is locking the knee, or even extensive mechanism. The patella can be dislodged. Now recently, my last A&E, the patient was actually transferred from Thangol to Colombo in almost like a dislocated knee.
because it is a nursing officer. It was not reduced, and it came all the way 6 hours it took for the patient to come to Colombo just to reduce it. I had to reduce it in the A&E. So these are things that you have to practice immediately. Okay, so again, go back one. So when do you, when to refer to specialists? So urgent vascular, if you suspect any vascular injuries, any knee dislocations, multi-ligament injuries, make sure you get the vascular team involved, okay? And you check the pulses and do the ankle brachial pressure index as well. Also, orthopedic referrals for any fractures, osteochondral fractures, any dislocations, extensor mechanism disruptions, ligament injuries, open fractures. In children, if you suspect anything, urgent referral is needed for orthopedic surgeon. Okay, so we are running out of time, so I don't have time to explain. This is a vast topic, so this is just a general overview as to what you do if you suspect any injury in a sporting person that presents to you. Okay, so take-home message. So acute knee injuries can result in long-term disability without appropriate early management. So it's important if you manage them properly, you can get a good outcome. Most commonly involves ligament sprains, ACL, the ACL and the MCL mainly, and of course the meniscal tears, patellar dislocations, fractures, and multi-ligament injuries along with dislocations. So detailed history examination and investigations will be able to come to a proper diagnosis, and appropriate treatment can be planned. So identify and treat these limb-threatening injuries urgently. An immediate reduction and stabilization of knee dislocations, multi-ligament injuries, and locked knees is very important. Remember price and immobilization methods, and urgent referral to appropriate specialties if you suspect fractures or vascular injuries or anything serious. Okay, thank you.
As there is no, I think the time is not allow for the further discussion and the questions. So thank you very much for all the speakers who participate in this session. Thank you very much.
Thank you to all our speakers for those excellent